Hi, my name is Major Lax. The innovation team and I would like to spend a few minutes with you today imagining and then proposing a different way to prioritize health and health care for our wing. Before we discuss changes, let's first define the problem. Musculoskeletal medicine is the most common reason 31st Fighter Wing personnel are non-deployable. It accounts for nearly 50% of our outpatient office visits and constitutes a significant portion of our members forced to undergo medical evaluation for retirement. This finding stands in stark contrast to the mandate of our DoD leadership to provide a lethal and rapidly deployable force. Additionally, some of our current processes create multiple barriers to rapid and effective treatments for many musculoskeletal conditions. Let's examine a typical scenario. Senior Airman Jones is a 25-year-old maintainer working the night shift. Over the past couple of weeks, he has noticed his left shoulder causing him pain when he is reaching up above him to work on the aircraft. He's advised by his supervisor to seek care to address the problem. Senior Airman Jones calls the appointment line and the medical group is able to offer him an appointment to be seen in 3 days. After completing his shift, Senior Airman Jones waits for his appointment, which is at 10 a.m., a time he would normally be home and in bed, resting before his next shift. He attends the appointment and is evaluated by his PCM, who diagnoses him with a simple strain of the rotator cuff. He's referred to physical therapy and prescribed anti-inflammatory medications to help with the pain. Senior Airman Jones activates his consult and is appointed to meet with the therapist on base. His appointment is scheduled with the appropriate referral timeline in 3 weeks. In the interim, Senior Airman Jones reports to his supervisor that he has too much pain when working on overhead projects and asks to have modifications to his workload. He has his appointment at PT and begins his rehab, performing his exercises as instructed. After 12 weeks in rehab, his pain is improved but still limiting him from working at his regular duties, and he is advised to return to his PCM for a follow-up visit. After speaking with the PCM, Senior Airman Jones gets an x-ray and is referred to orthopedics for additional consultation. He is again provided an appointment within the access metric and is seen in 2 weeks. Based on the exam, the orthopedist now asks he obtain an MRI to better evaluate his rotator cuff. This happens in 3 weeks, at which time he has scheduled his follow-up appointment. Senior Airman Jones has been working to improve his shoulder for the past 20 weeks, all the while needing modifications to his duties and taking extensive time away from work to rehab and doctor appointments. Referral to community physiotherapists are commonly a 15 to 30 minute drive one way, and when factoring in the time to change, etc., a single rehab session may take as much as 2 to 3 hours out of the duty day. The care delivered to Senior Airman Jones is according to good practice standards according to AFMOA and most civilian healthcare organizations. However, it's in contradiction to our mandate as an operationally minded medical force intended to provide a maximally deployable and readiness force. So, let's imagine something new. Learning from the work of our AFSOC and Guardian Angel communities and their associated POTF, meaning Preservation of the Force and Family efforts, what if we provided a rapid evaluation and treatment sensitive to the operations of our units and their unique requirements in an evidence-based and high-touch way? How might we do this? We recommend the introduction of a new clinic intended to meet the needs of our active duty force. It will be called the COBRA Clinic, standing for the Comprehensive Operational Medicine for Battle-Ready Airmen Clinic. Learning from the lessons of the Viper Clinic initiated 4 years ago at BMT in Lackland, we know that embedded musculoskeletal providers can have a powerful impact on return to duty rates, minimizing missed work days and need for profiles. We propose creating a hub and spoke model of care using local national Italian physiotherapists as 6 separate spokes connected to the hub of our Reliability Operational Clinic, or ROC. Each physio would be assigned squadrons for which they're primarily accountable. Some of our larger squadrons, the 31st Security Forces Squadron for example, would require 1 full-time physio to care for their members. Alternatively, some of our smaller and less physically challenged squadrons can share a single physio who would provide regular times in each of the squadrons. Each of these spokes would provide care at the point of injury, in each of their squadrons utilizing portable equipment focused on rehabilitation and prevention of injury. Within their focus would be 3 primary concentrations. Number 1, preventive care, or trying to avoid injuries. Number 2, rehabilitative treatment of musculoskeletal injuries, focusing on prompt diagnosis and early intervention. And number 3, medical readiness tracking for their respective squadron, providing squadron commanders with stickman reports on the deployability of their airmen, designating each airman as green, yellow, or red based on agreed metrics for each specific career field. The spoke would ideally have the additional resource of a 4N responsible for much of the day-to-day medical needs of the squadron and completion of readiness-related tasks. Not every need or condition will be able to be adequately addressed in a spoke, at which point the hub will become increasingly important. Each of the spokes can refer back to the hub to get immediate feedback from a musculoskeletal provider. The hub would provide capabilities such as musculoskeletal diagnostic ultrasound, injection modalities, pain-relieving treatments such as acupuncture and therapeutic dry needling. Importantly, any interventional procedure would be carried out in the hub to comply with medical standards of practice. Patients can be treated and subsequently returned to their respective spoke with instructions and treatment recommendations. Fundamental to this model is the availability of rapid access to definitive care. Each spoke will have open access hours aligned with the mission of the squadron. This may be shift change or early morning during squadron PT time. Members will not need appointments and will be able to walk in to see their spoke providers. If a higher level of care is deemed necessary, the hub will also offer walk-in availability. Importantly, we are recommending changing the paradigm for our active duty population and creating a new standard. Acceptable access to care is redefined as when it is least disruptive to the unit's mission and as soon as the patient can be available. Our spokes will be given the charge of focusing on recovery as well as rehab. Through the use of various modalities, the teams will be able to minimize downtime. We may not be able to modify the intensity of their day-to-day duties, but we can help our airmen prepare for tomorrow's tasks or battles. Imagine a defender getting off a 12-hour shift and being able to ice down a sore knee, or a MUNS member who has been moving heavy weapons can get a quick stretch on the low back from a skilled provider. Let's return to Senior Airman Jones's case and imagine how it may have been different if the Cobra Clinic was available. Senior Airman Jones would have gotten off of shift and perhaps gone to ice down his shoulder. If it was bothering him, a physio who already knows him and his job does a quick evaluation and recognizes his weakness is greater than expected for a simple strain. The physio refers him to the hub for a closer look. At the hub, the provider performs a musculoskeletal ultrasound and identifies a partial rotator cuff tear that would be effectively treated with a particularly rehab strategy. Those results are relayed to the therapist, who can begin daily rehab with Senior Airman Jones with the confidence of having a firm diagnosis. Senior Airman Jones, after 3 weeks of strengthening, is able to be back to full duty without limitations. Another airman returned to the fight and a valuable human asset maintained. Thanks to some innovation within our Air Force, some assets are already en route to provide similar care to our aviators. The optimization of the Human Weapon System program will provide 2 spokes, one in the nickel and one in the buzzards. They will work seamlessly with the Base Operational Support Team, or BOST, assets inbound as part of the Health Promotions Team, which will fall under the direction of the Cobra Clinic. This plan requires initial investment to provide personnel and equipment to make it a reality. In particular, we recommend hiring 6 local national physiotherapists to primarily serve in the spokes. Additionally, we recommend a request for additional IDMTs and/or 4Ns to provide traditional medicine within the spoke clinics under the guidance of AFI 48-149, outlining care in the embedded ambulatory care unit. 4Ns or 4NFs, depending on the mission for the squadron, will be needed to integrate the care between the traditional medical group structure and the Cobra Clinic. Initially, we recommend using the Flight Medicine Clinic as the hub. However, moving forward, an investment of space will see this model flourish. A properly equipped hub would require approximately 1,200 square feet of open space to house unique rehab equipment such as gait retraining equipment, Alter-G treadmills for rehab, hot and cold tubs, along with the possibility of a float pod for sensory deprivation. 2 potential spaces currently exist: the Health Promotion Building or the inpatient care floors at the medical group, which would require some renovation. When not seeing patients in their spoke clinics, the physiotherapist would be able to return to the hub to provide more advanced rehab for members in need. Members of the BOST initiative will be ideally suited to provide broader recommendations, including individualization of teaching of PTLs and mentorship on strategies to suit the needs and mission sets of the various squadrons. Health Promotions would provide a rotation of available nutritional education and guidance to members, regardless of BMI and PT test scores. By integrating these important prevention strategies within the squadrons, we can begin the challenging work of reshaping our squadron cultures, seeing their health as a mission-critical skill set which cannot be ignored. This is a big ask. It's going to present both opportunities and challenges for our medical teams and line leaders. Changing the tide is never easy, but it's the right thing to do for our mission and our people. So it leaves us with a simple question. Is our Air Force's go-to fighter wing ready to lead the way?